Our injuries for the posterior lower leg lab, we have three. Um, one, one chronic and two acute traumatic injuries. So first one we'll start with Achilles tendon rupture, and this is an acute traumatic injury. Usually the athlete reports that they pushed off, maybe they're trying to change directions and propel themselves forward, and they uh, felt like somebody kicked them in their heel. Um, Almost everybody reports the same thing. They look back to see who hit them in their heel, and there's nobody around or nobody close enough to have kicked them in the heel, certainly. Um, I've had an RCMP officer who was out playing rugby with some friends in a field and felt the sharp pain in his heel, and his first thought was that one of them had shot him in his heel, because that's what it felt like. Or another patient who um, ruptured his Achilles snowboarding many years ago, and then he rehabbed that. And he was at home walking downstairs. They have a cat, and he felt himself about to step on the cat's tail, so he quickly shifted his weight to the other foot, and he ruptured his other Achilles tendon in the process. Quite often, these individuals have had a history of Achilles tendinopathy, so chronic tendon pain, degeneration, maybe some thickening of the tendon, so the tendon is weaker, and that's what predisposes them to having this rupture of the Achilles tendon. So again, as part of the history, they're going to have difficulty walking. They'll say it's hard for them to push off on that side. Pain, swelling, maybe some bruising in the posterior lower leg. When we do our assessment, we watch their gait. There's going to be a noticeable limp on the injured side. If we ask them to go up on their tiptoes, they won't be able to on the injured side, or they'll have great difficulty doing so. When we go through range of motion, our active range of motion is going to be pretty well normal. And you think, what about plantar flexion? How are they plantar flexing their ankle? Well, usually if we have people sitting on the edge of the table and ask them to plantar flex their ankle, gravity is going to pull down on their foot. So it's going to appear like they have normal active plantar flexion. But when we get into our passive range of motion, we're going to be able to bring the injured side into much greater dorsiflexion than what we can the non-injured side, because there's no restraint. The calf muscle is not attached to the calcaneus anymore, so it's not going to restrict their dorsiflexion. And then especially with our strength testing, when we strength test plantar flexion, they'll have minimal strength or little to no strength on the injured side for plantar flexion. Our Thompson test, so where we have them laying face down, squeeze the gastroc heads, looking for plantar flexion. A positive test would be no visible plantar flexion in the ankle. A negative test would be if we see plantar flexion happening. And then we palpate the gastroc soleus and down to the Achilles tendon. We'll feel the defect within the tendon. So treatment, if we suspect Achilles tendon rupture, we're going to send them to the hospital right away. Now, they may or may not do surgery depending on the person's activity level, how old they are, health history, all of those things. If they do surgery, it'll be within a matter of days, and they'll reattach the torn ends, and then they're put in the walking boot with the heel lift, so there's not stress through the Achilles tendon, and they gradually decrease the height of that heel lift over the course of 3 months until the athlete gets into neutral position, which is the position of our ankle when we're standing on the ground. If they don't do surgery, then they're just put in the walking boot, and they allow the body to just scar up and lay down those collagen fibers between the tear, and same thing, they gradually decrease that heel lift over the course of 3 months. Once they are able to stand in neutral position, they no longer have the walking boot with the heel lift anymore, then that's when we start working on the rehab, and we need to work on their ankle dorsiflexion, because we need that 10 degrees of dorsiflexion for walking and 20 to 30 degrees of dorsiflexion for running. So we need to work on stretching the gastroc and soleus and some scar tissue mobilization through the Achilles tendon itself, and then our strengthening, balance proprioception, running progression, and return to sport. Achilles tendinopathy, this is our chronic injury. So initially, when it first happens, there may be tendinitis, so signs of inflammation, redness, swelling, heat coming off of the area. But if they continually do those stressful activities on the Achilles tendon, then we're going to no longer see the inflammatory changes, but rather degenerative changes within the tendon. So the collagen fibers are no longer lined up in a linear pattern. They're a bit more disorganized. We'll see neovascularization, or tiny little blood vessels growing into the tendon, trying to help it heal. They'll have pain, and if we visually look at the Achilles tendon, we may be able to see a bump in the area. So for assessment, gait usually is normal. If they have a lot of pain, there might be a little bit of a limp. When we go through range of motion, plantar flexion will be normal, but dorsiflexion may be decreased on the injured side, both actively and passively. Strength is usually good with this. They might have just a little bit of discomfort on the injured side when we strength test plantar flexion. We'll palpate the Achilles tendon. We will feel a bump, usually 2 to 6 centimeters proximal from the calcaneal insertion, and it'll be tender in that area. Footwear sometimes can be a contributing factor. We'll look at their footwear and make sure it's appropriate for the activity that they're doing and how they run. And if we think something's wrong with their footwear, then that's part of our correction or treatment. We'll try to stretch out gastroc and soleus so there's decreased stress on the Achilles tendon, strengthening, isometric, isotonic, and eccentric. And our eccentric loading is key part of the rehab. I'll do a video of it to demonstrate. For isometric strengthening, we can just push our foot up against the wall, so we're contracting the gastroc and soleus, but the muscles aren't changing length. For isotonic, just our toe raises would count for that. And then eccentric, you're usually standing on the edge of the step with the forefoot on the edge of the step. Use your hands and both feet and ankles to go up into plantar flexion, and then you take all the weights off the non-injured side and you're solely weight bearing through the injured side, and slowly lower the heel down so it comes below the level of the step. So we'll start with 1 set of 10 repetitions, then build up to 2 sets, up to 3 sets, and when they're getting 3-4 sets of 10 with no increased discomfort, then we can add some weight to it as well. So maybe a backpack with some weights on them. For return to sport, after working on strengthening, balance proprioception, running progression, we may do our Achilles tendon tape job on return just to limit their dorsiflexion, to take some of the stress off the Achilles tendon. Calf strain is acute injury, can occur in either one of the gastroc heads, usually mid-belly. It might happen at the musculotendinous junction, so where the gastroc or soleus is attaching to the Achilles tendon. Different things that can contribute to this: improper warm-up, dehydration, cold weather, all of those can play a factor. With our assessment, they may have a limp. We may see some swelling and bruising over the area a few days after the injury, especially with our higher grade strains, grade 2 and grade 3. When we ask them to go up on their tiptoes, they'll be able to do it, but they might have increased pain. For our range of motion assessment, active dorsiflexion will be decreased on the injured side, both actively and passively. And then for strength testing, resisted plantar flexion will be weak and painful. When we palpate over the gastroc and the soleus, they'll have increased pain. For our higher grade strain, we might be able to feel a defect within the muscle belly. So treatments, police, we may put heel lifts in their shoes to take some stress off the calf muscle. We don't want to aggressively stretch the muscle for a week to 2 weeks, because with the strain, the body's laying down collagen fibers into the the torn area, trying to heal the tissue. And if we're stretching that area too soon, it's just going to tear apart those collagen fibers that are trying to help it heal. As the pain settles down, then we can get into our strengthening, isometric, isotonic, and eccentric. And then similarly, we can do Achilles tendon tape job to limit dorsiflexion. Some people will feel some benefit from compression through the calf as well. So either compression wrap with stretchy tape, or even a compression sleeve or a compression sock they can wear on return to sport as well. So that's it for our injuries for the anterior lower leg.